Thank you for inviting me to speak today on something I'm very passionate about, and that's the care of babies who are born with cleft lip and palate. Just for my own selfish purposes, of the pediatricians in the room, how many of you all see, or the primary care providers, how many of you all see babies who are just born who have cleft lip and palate and haven't seen a cleft team or don't have an appointment with the cleft team yet? It's hard to know whether families are getting the proper prenatal counseling, and that's something we try to do, obviously, as soon as we can. My name is Buchanan. I'm the director of the cleft care team here at Texas Children's, and so hopefully by the time we get through the slides, you'll have a better understanding of how we take care of cleft lip and palate at Texas Children's Hospital, which follows the standard at the American Cleft Lip and Palate Association. So we're going to go over the overview of cleft care, the treatment timeline, which is probably the most important piece of information when it comes to this talk, the management in early infancy. Then we'll discuss briefly the lip repair, the palate repair, and then some other operations that we commonly do for babies and then young adults who are born with a cleft lip and palate. So when it comes to cleft care, we have a structure to our clinic, and from the birth to late adolescence, the care goes through that whole time. So it's not fragmented care. We see these kids every single year to make sure that they are on their appropriate track. And each track is specialized for them, depending on what they have. We do an annual follow-up, like I mentioned. The importance of the multidisciplinary team cannot be overemphasized. This is not something that should be treated by an individual practitioner in a silo. This needs to be done by folks who are at a big center and know the proper resources they should get throughout their lives so that things aren't missed and nothing falls through the cracks. We have a weekly cleft clinic here where we see between 60 and 70 cleft kids, prenatal to 18 when they graduate through. Sometimes we see older folks who haven't gotten cleft care, and we operate on those folks too. So this is the timeline that you have in your folder. As you can see on the very right is the prenatal visit, and this is where the mom and dad will come in and they'll have their 20-week scan. And at the 20-week scan, something's found, and they're nervous, and so we put a lot of their fears to rest during that visit. And then on the top is the therapy and the treatment. On the bottom is the surgeries that we do. So just if you kind of look at a small section of it, if you have a baby who's born with a cleft lip and palate, by the first year of life, they'll have 2 operations done: a lip repair at 3 to 4 months, and then a palate repair about 10 to 12 months. And then they shouldn't need any other surgery until they're about 7 or 8 years of age. So if you hear of a baby who's had, or a toddler who's had 5 to 6 to 10 operations, something's wrong. That's a problem. Kids with clefts should have 1 to 2 operations in their first year, and then after that they don't need anything else until about 7 to 9 years of age when they need a bone graft operation. There are some revisionary things that we can do. However, that's not standard for what we do here. We don't normally have to do those. Those are usually on patients that are referred in from other places. So the early infancy, this is when baby is born and they come in with mom and dad and they're overwhelmed because they have a brand new baby, and now they have a baby who has a cleft. So that's a little different story. So the feeding is the number one thing, feeding. I want to make sure that you all know that babies who have clefts don't need to go home from the hospital with a feeding tube. They can feed just fine with a bottle. It's a modified bottle, and we'll talk about that, but they do not need to go home with a feeding tube. There's some family counseling that goes on with all the members of the cleft team. We do the appropriate referrals. We try to make sure that every single person on the multidisciplinary team will see that family that day. So it's a kind of a long day, maybe 2 or 3 hours they're in the room, and I would run through maybe 20 different specialists come in to talk to them about the care and answer their questions. Most families, after we talk to them, feel very good about their appointment and very good about the future of the care their baby's going to get. And then I'm just going to mention something about nasal alveolar molding. That's an orthodontic device that we use here to try to help clefts get a little bit smaller. So in the very first day to 2 of life, these 2 devices we use to help a baby feed who has a cleft lip and or palate. The Haberman feeder there on the left and the pigeon nipple on the right. The Haberman feeder essentially is built with, it's a bottle but has a reservoir on the end of it. And the mom or the dad or whoever's feeding the baby has control of that reservoir. So the milk goes in the reservoir and they can control. You can imagine a baby who has a cleft lip or palate has trouble with suctioning, and so they have a hole there, so you have to help them out. But once the milk gets into their mouth and their throat, they're able to swallow, no problem. So it becomes a little bit of an education, but most families pick it up, within a day or so. and the babies pick it up straight away because they know how to swallow. And the pigeon nipple, the one on the right, the difference in that is that nipple just has a very large aperture so that the milk kind of comes trickling out of it. So babies get it in their mouth. They don't have to they don't have to generate a huge suction. They can just kind of mash down on it and the milk will come out of it. In that first visit that we see them, we talk about something called nasal-alveolar molding. It's a specialized technique that we've had in the last 20 years, developed in New York, where we try to make a wide cleft a small cleft. So it makes the operation a little bit easier for us, and we think it makes the results a lot better. So what it does is essentially it's an orthodontic device that goes in the mouth, and we use passive tension to bring the cleft segments closer together. So if you see on the baby on the upper left here, that's decently wide cleft, and you can see the nasal ala on the right side is flat. And then if you look inside the mouth at the cleft, you see that these two segments here, this is one part of the palate, this is the other part of the palate. What you're looking at here is the vomer of the nasal bone. You're looking right into the nasal cavity there. So you look at that and you say that's a decently wide cleft. We can fix it, and lots of people do fix it, but is there anything we can do before we do surgery to make it a little bit easier? So Dr. Worthland, he's our orthodontist here in the clinic, and he does something called NAM, which is nasal alveolar molding. Alveolar molding, this is the alveolus here. And so by using a plate and a passive device and those little rubber bands and the tape across the face, you can use that pressure to pull the segments of the alveolus together so that there's really no space. And then he puts a little flange inside the nose at the end of the nasal-alveolar molding to push the ala up so that it matches the opposite side. So if you're a cleft surgeon and you look at that lip and nose compared to the one we saw before, you're like, wow, that's a little bit easier. That'll be a nicer day for me. So this is an example of a NAM device for a bilateral cleft, and we'll kind of talk about the differences in a minute here. It has two little nasal flanges because babies who have bilateral clefts have a really wide and a flat nose, and we want to help give them a nice projection to their nose. Okay, so the major surgeries any baby with a cleft lip and palate, let me emphasize and palate, they need within their lifetime are a lip repair at 3 to 4 months. We wait 3 to 4 months because we want babies to have started gaining weight and to be robust and to be able to tolerate that surgery well. Sometimes we do trips to other countries where we fix lips and palates, and there's a heavy screening process for anesthesia. And a lot of babies come in, they're very frail and small, and if you put a baby like that under anesthesia, there's a chance that they may not come through. So it's really important that we screen these patients. In America, it's usually never much of a problem, but in other countries it is. So 3 to 4 months of age. We do the primary palate repair where we put the palate together. We do that at 10 to 12 months. We don't combine those operations because the palate operation is an airway surgery. And as you all know, ABC, airway is the most important thing. So we want their airway to be as big as possible before we close it. But the other side of that is we want to do it before they start making tons of sounds because we want to make sure that they use their palate to make all their sounds with and not have to develop compensatory mechanisms to make sounds and then unlearn those things. So that's why we time it between 10 to 12 months of age. The bone graft, which is the cleft of the alveolus through the teeth segment, is done at 7 to 11 years of age. And then cleft septorhinoplasty, which most kids get, is done when they're fully grown, 14 to 16 years of age. And that's usually their last surgery that they have. After that, they graduate from our clinic and go off to college or whatever they want to do. Okay, some other operations that we consider, sometimes we'll do a lip and a nose revision if we're not 100% happy with symmetry and how things line up. Every once in a while, we'll have to do something secondarily on the palate, which is a VPI surgery, velopharyngeal incompetence. Too much air coming out of the nose when they're talking. And that's because the palate usually isn't long enough and not contacting the very back of the throat to form a seal. And so air will sneak out and around the back of the palate through the nose and have a very nasally sound. So that's something that we want to correct. So you'll probably notice it when you're in a grocery store, someone's talking, you kind of notice it's kind of an irritating sound. And it's just sort of a social thing that you would want to have corrected so you can interact with folks. And then orthognathic surgery, essentially that means jaw surgery. It's very common for kids who have clefts, especially bilateral clefts, to need an operation to move their upper jaw forward. Lots of times they have a huge underbite, so their lower jaw is way in front of their upper jaw. And so in order to help correct the facial balance and also help their eating and to help their speech, you want to move that jaw forward so that their tongue makes good contact with the back of their teeth, so their teeth come together well so they can eat well. And also sometimes helps with some sleep apnea because if that jaw is really far back, it's pushing the palate back into the airway, and they have trouble with snoring and things like this. That's a bigger operation, but some kids will need that as well. So if you look at the spectrum of clefts that we see in our clinic and that you'll see in the community, it can be very, very minor, like the very top one there, where it's maybe just a little bit of a notch here. You know, most people wouldn't even recognize that. You can see maybe a little notch here. And some folks would say you don't have to correct that, but it's important just to be kind of aware. And then this is a little bit more of a notch, where you have a little bit of a nasal asymmetry on the side, and probably the muscle maybe isn't together. And then you get into something where it's an incomplete cleft, where the cleft isn't all the way through, but it's there, and you have a nasal asymmetry on the side. And then you have a very wide cleft and very kind of deviated nasal tip. And then you can get to something here where this is what we call a complete cleft, because it goes all the way through. Lip is separated, alveolus, the thing where the teeth are, separated, and the palate goes all the way back in a really flat nose there. And then you can get where the segments are really out of place and the nose is almost touching the alveolus here. And then you can get, on this side is a bilateral cleft, but it's an asymmetric bilateral, complete on the left, but incomplete on the right side here. And then you can get something called a complete bilateral, where you have the lip segments are not together. This is something called the premaxilla, which is a very central portion of your upper alveolus. This is something called the prolabium, which is the fleshy part that sits on the premaxilla. And you can see the nose is very flat. And there's no real columella here. And so you have to rely on Dr. Worthland. The columella is this little bit right here. It's kind of gone. So you have to rely on Dr. Worthland and some other folks to help kind of push the nose up to give us the columella. And so when it comes to evaluating a cleft, it's important to know what's normal and what's abnormal. The normal things that we are looking for when it comes to a cleft is obviously a normal nose, normal symmetry of the nose, symmetrical nostrils. This is very important. There's something called a Cupid's bow, which is the bow right in the middle of your lip. And then the philtral columns, these two kind of bulges that are ascending up from the Cupid's bow. And then just a nice symmetric vermilion as this comes across, this red part of your lip. And then you can see what's going on here. You see that the nose isn't symmetric, the ala are totally not symmetric. This is flat, this is a nice arch to it. The Cupid's bow is sort of sitting off to the side. It's not connected with this side. And that vermilion is really not symmetric at all. So once you start looking at these things critically, you start to see, okay, these are the things I gotta fix and I gotta make lip right. So the goals when it comes to fixing a lip are we want to preserve the natural landmarks. The good news is most of the tissue is there, pretty much all the tissue is there. It's just it didn't fuse during the 6 to 8 weeks of embryogenesis there. So we don't really want to throw away much tissue. We want to keep as much as we can because we want to use it all. We want to keep the scars along the junctions of the anatomic structure so that they don't lie with that, because your eye has a good ability to kind of pick up normal convex, concave surfaces on the face, and so we try to hide scars in those areas so that they're less noticeable. You want to make sure you repair the muscles so that they can form a nice pucker and they can form suction and all that kind of, and then when they talk and move their lips, they have the same ability to make sounds and words. You want to make sure that the nostrils are equal and symmetric. Your eyes are really good at picking up differences between the sides of the face. It kind of just scans the face when you first meet someone, and they're very good at kind of picking up things that are different. And then you want to look at the alar bases, which are the bottom of the alus, to make sure they're on the same plane. So these are all kind of things that we consider during the repair. A gentleman who was actually a graduate of Baylor College of Medicine, Ralph Millard, pioneered the rotation advancement technique. This is a repair technique that that's probably the most commonly one used in the world, and it's a good technique. It's a great technique. It's not a technique I use, but essentially what you're seeing here is his diagram of that. In order for him to make this Cupid's bow here, which is turned up, and this side is short compared to this side, he wants to lengthen this side, and then he wants to put these two together so that this philtral column and this philtral column are the same. If you look here, this philtral column are the same, right? This philtral column and this philtral column aren't quite the same. So you have to lengthen this side in order to get there. So how did Dr. Millard do it? Well, Dr. Millard did it by doing something called a rotation, where he did a cut here that rotated up, and he matched that length, and it was the same length as this philtral column, and then he advanced this tissue over. So it's a rotation advancement technique. And that's the most commonly used technique in the world at this point. This is the common technique that I use here, some other folks use here. Dr. Fisher is a gentleman at Toronto Sick Kids Children's Hospital, and he advocated same exact principles. You try to lengthen one side to match the side so that it's their symmetry. And he did this by just doing a little back cut here to drop this down, and then adding a little dart in here to make sure that back cut doesn't retract. And so things kind of line up nice and perfect. Now these are just pictures here, so you can make anything look perfect. So we'll just move on to the real thing. And the idea here is that we want to leave the scar along that filtral column. That's a natural convexity on the face, and it tends to hide scars better. So that's sort of the goal of that. So here's a little guy who we repaired. You can see he's got a complete cleft lip with some nasal deviation. And you can see our marks that we put on the face. We do these little tiny pens and ink and all this kind of stuff. So it's kind of fine and delicate work. And here's another little guy that we did, full complete cleft. And so here we are after the repair, and we use these little tiny blue sutures here because they don't leave that bad of a scar. We take them out a week later, and then we use these little nasal stents to help shape the nose. And you can see that the symmetry here is nice, and everything's lined up pretty nicely. And so, and then we'll see the baby back in a week or so. And so they have good symmetry there, good symmetry here. Scars not very well, and this is maybe only 2 weeks after surgery, so you can imagine with time this scar calms down, it's going to look really nice. And these little nostril stents we use for maybe 3 to 4 weeks. Babies don't really love those things, so you do what you can, but you got to listen to your patients too. So here we are before and here we are after, and so the goal is to try to get them to a point where the parents come back and see us and say, no one even notices they had a cleft, and that's all I need to hear. I'm really happy when I hear that. Here's just one more example of a little girl who's had the same thing about 3 or 4 weeks out. Still an immature scar, but looks pretty good. Just another example here. I can see our little darts and everything, and so that's kind of that. Here's a really wide one that we treated, and you can this one gives you a good example of kind of the nose shape that we can get after doing the NAM. Instead of being flat, see how flat that nose was? We're really able to kind of get it up. When it comes to a kid with a bilateral cleft lip, these are the surgical markings that we do, not as important here, but essentially these results are actually better than our unilaterals usually because it's a symmetric operation. And so you usually don't have the asymmetries between the two. So here he is during surgery, and then here we are after surgery. And so the nose, just comes right up there. And this is a very fresh scar, so with time that's just going to calm down. You can see he's got the tapes thing here. So we do taping after surgery to help with the flatness of the scar. Yeah. Here's another little guy. He was born with a really bad premaxilla, really far sticking out of the mouth. So we go and we fix it. We get good symmetry here. And then we have to see how they grow to see if we need to do anything else. So that's the cleft flip part. We're going to move on to the cleft palate part and talk about the goals of that. Unless anyone has a question. I'd like this to be kind of casual, but maybe we'll save questions for last. Okay, so the purpose of a cleft palate repair. So the purpose of this is to create normal speech. None of us are born with a hole between our mouth and our nose. We have a separation there. So if you have a cleft of your palate, there's going to be a hole there. So what that's going to make trouble is with feeding and with speaking. And so we want to fix that early on so that babies don't have any trouble with that. So these are the 4 kind of classifications of a cleft palate. The first one is something called a Vaux type 1. We named this Vaux because Dr. Vaux was a famous cleft surgeon, and so we named it after him. But Vaux type 1, this is just a cleft of the soft palate alone. A Vaux type 2, it's a cleft of the soft palate that actually goes into the hard palate. A Vaux 3, it's a soft palate, goes into hard palate, and then goes through alveolus, this horseshoe thing where your teeth live. And then a Vaux 4 is where it goes into both sides, like that. And then the repair techniques, families always ask me this, they say, where are you going to get the tissue from? There's a hole there, what are you going to do? Well, the good thing is that all the tissue's there. It's just not connected, just like the lip. It's all there. It just needs to be put back together. And so this diagram is a representation of how we do that for the Vaux 1 and 2 and 3. We essentially just elevate the tissues that's there and just put it together down the midline. So here's an example of a cleft palate repair. This torture device here looks like something in a torture museum is something that we use. It's called a Dingman mouth gag. Essentially, it's a gag that we put in when babies are sleeping. The endotracheal tube is actually sitting underneath this little tongue blade to hold it down, and that way we can work inside the mouth kind of comfortably, if you will. And then these little blue lines are ink, and this is where we draw the cuts out. And then once we make the cuts, we put everything together. There are some raw surfaces that we sometimes will leave here if the cleft is really wide. For instance, this is a pretty wide cleft. And these little areas will just fill in with normal mucosa within 2 or 3 days. So it's pretty great. There's a muscle repair component to this. You guys all know when you look in the mirror and say, ah, your palate jumps right up in the air. So that's something that we want to correct. That muscle that pulls your palate up is called the levator muscle. And so during our palate repair, we have to dissect that muscle and put it back together. And if we don't do that, then the efficiency of that palate is not as good. It's like connecting a bicep muscle somewhere where it's not supposed to go, and therefore you can't really get the full excursion of the muscle. So we want to make sure that levator muscle comes together in the middle and is nice and tight so that when babies or kids say ah or make sounds, that palate is working very efficiently and effortlessly. This is an operation sometimes that we do if the palate is too short. The way we see that is after babies have a cleft palate repair, we do a yearly speech therapy visit. And so our speech therapist will do a sort of a 45-minute evaluation process where they go through a cadre of words and sounds and make sure the kids are hitting all of them. If they're not, then we'll do something called a nasoendoscopy where we stick a small camera inside the nose and we look exactly how the palate is functioning in relation to the back of the throat. If it's short, and sometimes it can be because of scarring and things, then what we'll do is something called a lengthening operation or a furlow-palatoplasty. This lengthening operation, it's a Z. And we'll lengthen the palate. We usually get about 1 centimeter. We also reorient the muscles, those levator muscles, to make them tighter so that the palate will function better. So that's a secondary speech surgery we will do. So that's it. Primary palate repair, 10 to 12 months. Any revisionary operation on the palate, 3 to 4 years before going into kindergarten, so that kids are in kindergarten with good speech, keeping up with their peers, having no issues with speech. Okay, then kids are kind of free for about 5 to 6 years until they need a bone graft. We saw before there's that alveolar segment that's associated with a cleft where the teeth live. Now, we have to put bone in there because baby teeth will come in and that's fine, but when the permanent teeth start to erupt, you'll see 7 to 11 is mixed dentition. When the permanent teeth start to erupt, if they erupt around the cleft and there's no bone in there, they'll just fall out. And as you all know, we only get one set of teeth, well, one set of permanent teeth, so we want to save them as much as possible. After that, you have to get implants and expenses and all this kind of stuff. So we do our best to save the teeth that they have. So between 7 to 11, the reason the range is so broad is because it's kind of based on their tooth development. So we'll get an x-ray starting 6 or 7 to see where their canines or lateral incisors on the cleft side are. And if they're coming down rapidly, then we'll know we'll have to do it earlier. If they're delayed and up there in the maxilla, then we'll go later on. So yeah, prior to the eruption of the permanent canines when we want to graft. We want to graft about 3 to 4 months before that canine erupts so that when the tooth erupts, it comes right through our bone graft and is nice and solid. The most common place we get the bone from is the iliac crest. The bone is not like what you're thinking, like a big chunk of bone. We harvest the cancellous bone, which is the sandy bone that's in between the hard bone of the iliac wing, and so it actually forms a nice packing surface that the teeth will erupt through. So that's about a 1.5 hour operation. The kids will stay in the hospital for maybe 24 hours and then go home after that. So this is an example of that. This is a child who's got some braces on. You see our Dingman mouth gag again. I'm sorry if it's kind of archaic, but we have his teeth here. He's been in braces. This is the alveolar cleft. You can imagine that there's a bony cleft that goes way up through here. Okay. So what we do is we expose all this. We close all the holes, any holes that are still there from mouth inside the nose. And then this is the iliac wing here. This is a nice slender person here for an iliac wing. And so we do dissection. We take little pieces of bone out that kind of look like this. And these are spongy bone, and you can kind of pack these nice and tight. And then we pack it into the space here, and then we close it up, and then we let it heal, and then with time, we go get, usually 3 or 4 months after we get an x-ray, we show nice bone formation there, and then you see the canine here, it's already coming down. So, so this is sort of what we're looking for. And then the cleft rhinoplasty operation, This is common because as kids grow, even if they've gotten a perfect nose and lip repair, perfect, even if they've had a great repair, as growth happens and faces change, things don't always grow appropriately, especially if you put scars in faces. Scars don't like to grow that well. So they inhibit the growth on the cleft side. So we do things when they're 17 or 18 to try to make things more symmetric. Here's a pre-op patient that we have, and he's got, the cleft is on the left side here. You see his nose is down on that side. There's a little bit of deviation. There's a root. He also has kind of an ill-defined tip, so we want to help him with that. So then afterwards, we straighten him up. He's got a little bit more of a defined tip, and his symmetry is a little bit better on that side. Not 100% perfect, but it's better. And the other thing that we do is we straighten the septum. The septum is usually deviated, so they had trouble breathing through the cleft side nostril, so we just essentially make that straight. The orthognathic surgery, the jaw surgery I talked about, folks from New York did a study that showed that something like 48% of their unilateral clefts needed a jaw surgery. We don't necessarily see that much, but there is a percentage. I'd say maybe maybe a third of them do. The bilaterals are more common, maybe a half. So these kids will need a jaw surgery, and it's better for them. And then there is some mid-face growth deficiency, and that's why we have that. And the reason that is we think it's because of the scar from the cleft repairs, or maybe just something intrinsic to the cleft itself. So this is an example of the model surgery. When we do jaw surgery, we take models of the teeth, and then we move them around, and then we predict our movements so that we can get a nice appearance. So this is a girl preoperatively where she's got this mid-face deficiency here, and you see her chin. When you look at her, you say, oh, her chin is really big. Well, it's actually not that big. It's the mid-face is not very well grown. So when it comes to your face, you really want to have a nice convex profile. That's what they call facial balance. This where it's kind of like a concave profile is not considered to be as aesthetic. And so what we want to do is we want to move the jaw forward. What it does, it fills out the upper lip. It helps the nose projection too. It helps the teeth show. You can't really see it there. Plus, she also helped us out because she put some makeup on in that picture, but that's neither here nor there. Maybe she was feeling better about herself, you know. So anyway, so that's what we do. And this is the pre-op dental x-rays, pre-op, and then post-op, you move the upper jaw more anterior so that the bite is on. Helps with speech, helps with eating, and helps with confidence as well. And then we do things like secondary lip revisions. This is not a huge deal, but these are very simple, an hour or two. If we get kids who come in and the lip's not fully repaired well and not symmetric, we'll try to make things nice and symmetric. Same with the bilateral. If they come in where things are kind of wide and not really lined up, we'll fix them up like that. And then we talked about the palatal lengthening. We have an extensive amount of research here. All of our patients in our cleft clinic are followed in our databases. We have a cleft database, and we have a speech database. And we also follow their 3D photos and their shapes of their face as they grow. So we follow all these kids to make sure that we're optimizing their outcomes and we're not missing any opportunities. We also have a annual cleft camp, and the one this year is in March, where we grab a group of our cleft kids between a certain age, and they just meet kids who are like them, who have had surgeries done and what to expect in the future. And it's a really empowering camp, and the campers love it. So we encourage, if you know kids who have a cleft and want to come out to that, we'd be happy to have them. And here are the team members. I probably should have put this early, but that's okay. So here's our cleft manager. Her name is Julie. And then myself, Dr. Monson, Dr. Marisevich, Dr. Trong, Dr. Olorunipa. And then here's Dr. Worthland, who I mentioned, our orthodontist. Dr. Rosenberg and Dr. Chandy are our otolaryngologists. And then our speech therapists are Christina Wilson and Ellen Moore, and they help out significantly. And then these are the other folks who are in the clinic. So it's a very big clinic, and we need all these folks to help us get a good job done.